All right, let's talk about a diagnosis that's, pretty easy to suspect, but can be really tricky to actually prove. Cushing syndrome. If you're in your medical training, this is for you. We're going to cut through all the complexity and give you a solid framework for how to think about this. Let's jump in.
So, you've got this patient in your clinic, right? We've all been there. Weight gain, new diabetes, high blood pressure. The list of what it could be is a mile long. But Cushing syndrome, that's when you just can't afford to miss. The thing is, these symptoms are just so incredibly common. So where do you even draw the line? How do you decide who actually needs the workup?
And that's exactly what this is all about. This isn't just about memorizing some facts for an exam. It's about building a real diagnostic intuition. We're going to walk through the whole thing together, step by step, from that first little inkling of suspicion all the way to finding the source. So here's our game plan. First, we'll cover the basics. What even is Cushing syndrome? Then we'll get into the clinical detective work, how to spot the clues. After that, we'll dive into the 3 main diagnostic tests, figure out how to hunt down the cause, and then wrap it all up with treatment and some really high-yield pearls you can use on the wards.
Okay, first things first, let's lay the foundation. What are we actually talking about on a fundamental level when we say Cushing syndrome?
At its absolute core, it's pretty simple. It's just too much cortisol for too long. Cortisol is our body's main stress hormone, and it has its hands in everything: metabolism, inflammation, blood pressure, you name it. So when those levels are sky high all the time, the entire system just gets thrown completely out of whack.
Now, this is absolutely key. The number one cause, and I mean by a long shot, is exogenous. It's the steroid medications we prescribe. So the first thing you do always is check that medication list. But when the body itself is the culprit, we call that endogenous. And in those cases, about 70% of the time, it's a pituitary adenoma, with adrenal tumors making up another 15 to 20%.
All right, now we get to what is maybe the most important clinical skill of all, figuring out which patient actually needs this big workup in the first place. You don't want to test everybody, so you need to have a really high clinical suspicion. Let's talk about how to get there. You see, obesity, high blood pressure, diabetes, this is the bread and butter of general medicine, right? And while they are definitely features of Cushing's, they are so unbelievably nonspecific. If you tested every patient with these, you'd be chasing your tail all day. You need something more to go on. And this is that something more. This quote is a game changer. We are not talking about the little pale stretch marks lots of people get. We're talking about wide, deep purple, almost angry-looking streaks on the skin. If you see these on your physical exam, your suspicion level should just go through the roof. And there are a few other textbook signs to keep your eyes peeled for. Things like proximal muscle weakness. Ask your patient if they have trouble getting up from a chair. Or those classic supraclavicular fat pads, sometimes called a buffalo hump. And also a persistent reddish complexion on the face, what we call facial plethora. When you see a constellation of these specific signs together, that's your green light. It's time to start testing.
Okay, so your clinical suspicion is high. You think this might really be it. Now you need the proof. You need to confirm it with lab tests. And there are 3 main first-line tests to choose from. Let's take a look.
These are your 3 workhorses: a 24-hour urine collection for free cortisol, a late-night salivary cortisol test, or the overnight 1 milligram dexamethasone suppression test. Honestly, the one you pick often just comes down to what's easiest for the patient and what your lab can do. But here's the catch. No test is perfect. For the 24-hour urine, if someone's making a ton of urine, it can give you a false positive. On the flip side, severe kidney disease can give you a false negative. The late-night salivary test, it's all about cortisol losing its normal day-night rhythm, so it's totally useless in a shift worker. And with the dexamethasone suppression test, you've got to watch out for certain meds, like some anti-seizure drugs that just chew up the dexamethasone before it has a chance to work.
So what's the big idea behind that dexamethasone test? Well, in a healthy person, if you give them a tiny dose of a powerful steroid like dexamethasone, their brain gets the signal to shut down cortisol production. It suppresses. But in Cushing syndrome, that cortisol production has gone rogue. It's autonomous. It doesn't listen to feedback. It just keeps on churning out cortisol no matter what. And that's where this magic number comes in. After the patient takes that dose of dexamethasone at night, you check their cortisol level at 8 a.m. If it's greater than 1.8 milligrams per deciliter, it means their body failed to suppress. That's a positive test. Seriously, burn this number into your brain. It's that important. So you've done it. You've done at least 2 of those screening tests, and they came back positive. You have officially confirmed hypercortisolism. But wait, your job is not done yet, not by a long shot. Now comes the next critical phase, finding out where all this extra cortisol is coming from.
So what do? What's the one single essential test you're going to order right now to figure this out? You measure the plasma ACTH. This one lab value is the fork in the road. It tells you everything. It tells you if the problem is being driven by ACTH coming from the pituitary or somewhere else, or if the adrenal gland itself has gone rogue, which would actually suppress the ACTH. And here's the algorithm laid out perfectly. If that ACTH level comes back suppressed, we're talking less than 5, the problem is ACTH independent. You've got an adrenal tumor just pumping out cortisol and telling the pituitary to shut up. Your next step? Image the adrenals. If the ACTH is normal or high, it's ACTH dependent, and you're going to start by getting an MRI of the pituitary.
And this is exactly what you might find. So following that ACTH independent pathway, you order an adrenal CT, and bam, there it is. You can see it clear as day, a round little mass in the right adrenal gland. That's a classic adrenal adenoma, and it's the source of all the trouble. Okay, we've found the problem, we've pinpointed the source. Now let's talk about the fix. And let's wrap this all up with some key takeaways you can bring right to your next rotation. For a cortisol-producing adrenal tumor, the definitive treatment is surgery. You take it out. But, and this is a huge but, the post-op management is absolutely critical. Think about it. That tumor has been suppressing the patient's other healthy adrenal gland for months, maybe even years. You can't just remove the tumor and walk away. And this is a clinical pearl you have to remember. That other adrenal gland? It's atrophied. It's basically been asleep on the job. It needs a long time to wake up and get back to work. This means your patient is going to need glucocorticoid replacement after surgery, and you have to taper it incredibly slowly, sometimes over months or even a couple of years as their own body recovers. So let's end with maybe the most important practical pearl of them all. After going through this entire complex workup, what's the single most common cause of Cushing syndrome you're actually going to see? It's that bottle of prednisone in their medicine cabinet. The biggest takeaway is simple, but it is so powerful. Before you order a single fancy test, always, always, always check the medication list.